there's been a lot of news lately about immunotherapies in melanoma, especially PD-1 and CTLA-4, and so I was going to focus on those drugs today. But just to show that immunotherapy actually is not a new concept in cancer treatment. And actually, William Coley, who was a surgeon practicing in New York City, was the guy who actually kind of brought immunotherapy forward. And he was a cancer surgeon working at the hospital that's a predecessor of Memorial Sloan Kettering. It was called Memorial Hospital in those days. This is in the late 1800s. And he noticed that a patient of his who was a German immigrant had sarcoma, and he was operating on that patient. It was a very difficult surgery. That this is on the days where I guess you have to be really quick with your surgery. But he noticed that post-operatively the patient developed an infection on his neck, and had developed a strep infection. And surprisingly, the tumor nodules regressed after the strep infection, even though that the strep infection per se wasn't good, but that made him think that the immune reaction to the strep infection might have helped in some way, And so he came up with this thing called Coley's toxin or Coley's potion. And in the beginning, in the 1900s in the United States, there were a lot of people going around making these toxins from bugs and from bacteria and from infections, injecting them at the site of recurrent tumors. And on occasion, they did work, and they worked in all kinds of different cancers. And so we didn't understand the mechanism of those treatments, and we didn't understand how exactly they were working until the mid-1800s, mid-1980s. And this is a picture of Jim Allison, who was at Berkeley at the time, kind of did these experiments just pre-holiday break, where he had some mice, and at the time there was this protein called CTLA-4 that had just been discovered by somebody in France, Paul Goldstein, working in France. It wasn't clear whether CTLA-4 was a immune stimulator or an immune inhibitor. And so Jim Allison actually got some antibodies to CTLA-4, injected them in mice, and that antibody was a blocking antibody, and surprisingly that seemed to clear the melanoma tumors. And the way that worked is, we now think works, is that T cells need to be stimulated by what are known as antigen-presenting cells, or some people call them dendritic cells. And these are the cells that take infection, take signs of infection like bugs or cancer or whatever, chew them up, and then present them to T cells. And by hooking up to two different receptors, the T cell receptor and something called CD28, and that causes the T cell to get stimulated. Now, the T cell needs to shut off that stimulation somehow. So what it does is it starts producing this CTLA-4 protein on its surface, and CTLA-4 is actually a way to shut off the T cells. And if you block that with an antibody, you can basically keep the T cell turned on for a long time. And so that's what causes, so you're blocking this T cell inactivation step by using an antibody to CTLA-4, and that basically keeps your immune system on and keeps it going. And so that's how Ipilimumab works. Now, in the mid-90s, a researcher in Japan actually made another interesting observation. He was looking at T cells that have run out of steam, run out of gas, gotten fatigued. And one of the proteins that's expressed a lot on those T cells is something called PD-1, or programmed death 1. And that, Tasuku Honjo found that protein. At the time, it wasn't clear it would be as effective because it didn't seem to work really well in mouse models of cancer. But what we now know is that PD-1 is a very powerful influence in human beings, in human cancers. And what we think happens is that, like for instance, if you have a tumor cell, whether you put a virus in it and kill it, or you radiate it, or even if it dies by itself or whatever, it will release these antigens, these little orange dots. Those are taken up by antigen-presenting cells or dendritic cells, and then those dendritic cells, using B7-1 and the major histocompatibility complex, latch on to T cells, and those T cells then go back from the lymph nodes, travel back into the site of the tumor, and basically kill tumors. Now what happens is that the tumors kind of have subverted this whole killing thing by producing PD ligand, or PDL1, and that can sometimes bind to PD-1 and turn off T cells. So kind of turn them off, prevent them from killing tumors. And if you block this pathway here, you can, either using PD-L1 antibodies or PD-1 antibodies, you can get your T cells to be much more effective in terms of killing tumor. And the first evidence that this was a very valid strategy for getting rid of tumor came in 2012 in this paper published in the New England Journal of Medicine, showing that in melanoma and kidney cancer and even lung cancer, which people haven't thought of lung cancer as being a very immunogenic kind of cancer, you could get lots of responses. And this is a spider plot. So these are, each of these little lines is one patient, and those little triangles and diamonds just show the size of a tumor plotted over time. So for instance, if you start off here, and if your tumor is gone totally, then you're like at this minus 100% line. If your tumor shrinks down 60%, you're in one of these lines. So you can see that a lot of these patients seem to have some type of benefit. So even this patient, whose tumor didn't shrink down a lot, still has disease control at least on to 100 weeks, which is 2 years after treatment. That's when the study stopped following these patients. And what was also noticed in the same issue of the New England Journal of Medicine was that blocking PD ligand also has a similar effect, maybe not as marked in this comparison. There's a lot of people who had their tumors increase in size, but a fair number did show reductions. And if you looked at the percentages, it was about 18% for melanoma, 17% for kidney cancer, and 10% for lung cancer. Just another way of looking at it, this is a study that we did at UCSF along with other places too. And this is just showing tumor reductions or increases. These are the folks who had increases, these are the patients who had reduction. And just showing that a lot of patients treated with PD-1, it was called Lambrolizumab at the time, now it's called Pembrolizumab, it's been changed, the name has undergone a change. But just showing that whether people had previous Ipilimumab or no previous Ipilimumab, that's the blue lines here, either way you could have a reduction. Just to show the point that whether you had previously had CTLA-4 treatment or not, the Pembrolizumab or PD-1 antibody worked just about as well. And this is one of our patients who initially had chemotherapy and had progressed. She lives in Reno, and she had a bunch of tumors in her lung. You could see that one clearly here. You could see this one here. And we started her on the PD-1 trial, and 12 weeks later, she apparently had an increase in her tumor size, which was disappointing. You could see that this higher lymph node here had increased in size by 12 weeks, even though this lung nodule had gone away. And that's something we see with immunotherapies, that not all tumors decrease, and sometimes you could even apparently have an increase in the tumor size. So she did have what's called pseudo-progression, and 24 weeks later, all of the tumors regressed, and actually now she's 3 years out, and in fact has been stopped. We've taken her off the PD-1. She had a complete response to PD-1, stopped PD-1. She's still doing as well as far as I can tell. And here's a patient who has an interesting story. His son was a fourth-year medical student at UC San Diego, and he had this. He was diagnosed. He had a lesion in his brain at the time, and also had pain in his leg. He had what's known as a pathologic fracture. The bone can sometimes break if there's tumor in there, and so he was treated by a surgeon who resected the lesion in his right leg. You can see that right over here. When he presented to us, we started him on the PD-1 trial, and he had this lung lesion. He had several bone lesions, and then by week 24, you could see that the lung lesion has disappeared, and the bone lesion also is no longer hot or no longer FDG avid, and he's also now 3 years out, no evidence of disease. And this is a patient actually from Salt Lake City who had come to us, from Huntsman to participate in the clinical trial, in the PD-1 clinical trial. And she had a treatment known as biochemotherapy at the time, and again had progressed in the lung. You can see that she's had a complete response, and again, she's free of disease so far as we can tell. This is a patient who was treated at MD Anderson. It's a rare kind of melanoma called desmoplastic melanoma, which tends to be very locally invasive and hard to get rid of surgically just because it's so, just spreads so much. And you can see that, he started off having surgery and it kind of extended over his eyes. He couldn't open his eyes. And a few weeks later, he could open his eyes just a little bit. And then 9 weeks later, you can see that he could open his eyes much more. And he's actually had a nice response to treatment. I'm going to skip over this. And one of the interesting things about patients treated with PD-1 has been that there's a kind of marker for PD-1 that's not 100% reliable, but it does give you some idea whether you'll have a response or not to PD-1 treatment, and that is by staining tumor for PD ligand, PD-L1. And so this just shows the usefulness, or I guess, or lack of usefulness of PD-L1 staining. So these are patients who are PD-L1 negative, the yellow ones, and the blue lines are patients who are PD-L1 positive, and this is a waterfall plot. So anybody on this side of the waterfall plot are folks who had a response. These are people who have not had a response. So I don't know if it's easy to see here, but a lot of the yellow lines are people who have not benefited, and there's a lot more blue versus yellow here, and a lot more yellow versus blue here. So just to show that if you don't have PD-L1 expressing tumor, those probably won't respond well versus those who are PD-L1 positive. One other promising approach has been combining the two, CTLA-4 and PD-1, and this is a study that was presented by Jed Wolchok and has been published in the New England Journal of Medicine in 2013, just showing that if you add Ipilimumab, which is a CTLA-4 antibody, to PD-1, you can get drastic responses. And these are just showing that a lot of patients have like 80 to 100%, almost complete disappearance of tumor within 10 to 20 weeks of starting treatment. And this just shows the waterfall plot. And I'm going to skip over this. The one problem with this combination approach has been side effects, and there's been a lot of side effects reported, especially skin side effects and diarrhea, and in our jargon, grade 3 or 4 side effects are those which can cause serious problems, to the point that you need to be admitted to the hospital. You can see that some of these events were like the colitis or diarrhea, and serious abnormalities in your lab function tests can occur with this combination. So at this point, I personally think that this is something to be reserved for folks who we don't think will respond to PD-1 by itself, just because PD-1 itself is relatively easy to tolerate. And so when you're doing this combination, you may have a lot of side effects versus just doing PD-1 by itself. And there's a lot of different trials ongoing with PD-1 or PD-L1 agents in the United States, including in melanoma, but also in kidney cancer, lung cancer, and even in head and neck squamous cell cancer, which again hasn't previously been thought to be an immune responsive tumor like melanoma. There's data that, and maybe Alan will talk to us about that. That's his other job is he treats patients with head and neck cancer, and that's become a big treatment modality for head and neck cancer. I'm going to skip over this. I think one other interesting immunotherapy has been what are known as CAR T cells, or chimeric antigen receptor T cells. And it's something that's been pioneered by Carl June at the University of Pennsylvania. And basically what he did is that in terms of the whole cycle of killing, instead of you giving patients PD-1 or CTLA-4, which works here, he thought, well, what if you just take T cells from a patient put the receptor that you want so that they can fight tumor cells, grow them in a petri dish, and then put them back in. And what if you just bypass all of these steps and just put the T cells right back into a patient? Would that work? And the answer is that it can sometimes. And basically what he did is, like, he would use a lentivirus, which is the same kind of virus that causes AIDS, but this is a highly modified lentivirus, and basically infects T cells, makes them, killer T cells, transforms their appearance so that they're, and their function so that they're killer T cells, and basically you grow them in a petri dish, and then make them proliferate, and then re-infuse them back into a patient. And here's a patient who he was published in the New England Journal of Medicine in 2011. And this is not a patient with melanoma, but just showing that this can work. This is a patient who was infused with this lentiviral vector, and just showing that these lymph nodes, you can see that over here, responded. This is a patient with lymphoma. So it's showing that this approach could be promising in lymphoma. And unfortunately, like the combination Ipilimumab plus PD-1 study has a lot of what we call grade 3 and 4. So this is just patient 1. This is just one patient. And if you just read this entire history that was published in the New England Journal, so you had febrile neutropenia, hypotension, vascular leak syndrome, required life-threatening, not pretty reading in terms of the side effects. And this is patient 2, had encephalopathy, which is another way of saying, brain swelling. So I think there's a lot of potential to this, but it's kind of a work in progress in my opinion right now. And I think there's a lot of refinements and tuning that needs to be done before it can be used for patients with melanoma. And this is my claim to fame. Rich Heller, my collaborator, came up with this idea of doing electroporation using electric currents to get plasmids or to be expressed in human beings. And so this is just a picture from when I had much more hair than I have right now. So it's a simple idea that in order to get DNA into cells, you basically need to break the cell membranes. And what you can do is you can use electric pulses to do that. Electric pulses will open up tiny pores in cell membranes, just for a few microseconds. And you can actually get DNA pieces or plasmids into cells using electric pulses. And we focused on using interleukin-12 primarily because it's a danger signal used by the immune system. It works on both NK cells, which are our innate immune system, and also on T cells, which are the adaptive part of the immune system. And interleukin-12 given IV is toxic. It's effective, but it causes a lot of side effects. And so we figured, well, maybe we could get rid of the toxicity, but still have the effectiveness of it if we just put it directly into tumors. And this is a patient we treated a few years ago, and he's a guy who had flank melanoma. He had surgery and he had radiation. You could see that these are, like Dr. Hanbecker was showing, these are what are known as in-transit lesions. So we started treating him on day 1, 5, and 8. And by day 39, it looked like he had a whole bunch of more tumors. We only treated him with 4 lesions. You could see all of these tumors appearing. And by 6 months later, you could see that this is not my fault. This is a wound dehiscence that I blame the surgeons for. So it wasn't the treatment that caused that to happen. But you can see that all of his in-transit lesions are gone. And then this is a patient that we treated who had like chest and back lesions. And we treated 4 of these. That's 2, 3, and 4. And you could see that months afterwards, you could see that this red patch appeared on his back. And we call this vitiligo, and ultimately all of his lesions disappeared, and he did well. And this is another patient we treated. She was a lady who had in-transit lesions on her leg, and lymph perfusion was used, so she actually had lymph perfusion at Moffitt Cancer Center where I used to work before. And you could see that we treated 4 of these lesions, and then by about a year and a half later, a lot of these appeared to develop this kind of depigmentation around them. And you could see that the yellow color that her limb had became red, that's because she had a lot of lymphadenopathy from swollen lymph nodes in her groin. Those lymph nodes, okay. Thanks, Samantha. Okay, I'm going to wrap up here. And just basically just talk about the fact that immune therapy has a lot of potential, not just in terms of revving up the immune system all over your body, but also local immune therapy, like Dr. Hanbacker was talking about, where you could use the tumor to basically produce its own vaccine. And we've had vaccines have been a bust in melanoma, in terms of producing any kind of meaningful responses. And I'm ready to confess that we've been barking up the wrong tree. But I think if you could use the tumor as its own vaccine, you can actually produce a lot of benefit, both in terms of educating the immune system and using it along with PD-1 and using it along with other types of immune therapy to produce a meaningful response for people. And with that, I'm going to end and let Alan talk about targeted therapy. Thank you.